Our next speaker is Dr. Kelly O'Brien. Kelly is an associate professor in the Department of Physical Therapy, cross-appointed in the Institute of Health Policy, Management and Evaluation, as well as Rehabilitation Sciences Institute at the University of Toronto. Additionally, Kelly holds a Canada Research Chair in Episodic Disability and Rehabilitation. And just to plug, Kelly has done pioneering work across Canada and globally on episodic disability, the concept of episodic disability. Kelly is also the chair and co-founding member of the Canada International HIV and Rehabilitation Research Collaborative, which we fondly refer to as CIRC. And she's also a CTN Clinical Trials Network investigator in the Clinical Care Management Core. Welcome, Kelly.
Thanks, Tammy. Thanks to the CanLive grant team, Realize, and the CTN for the invitation to present today. And I'm going to be talking a little bit about my experiences with a research project and looking towards trying to bridge the research into real-world practice. So first of all, I'd like to acknowledge the land in which I have the privilege to live and work, and that is the land in which the University of Toronto is situated, the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit River. And as we gather today for this session, I really acknowledge and I'm grateful for the privilege to live and work on this land that has been the land of many Indigenous people from across Turtle Island. I'd also like to acknowledge a number of value implementation of a community-based exercise intervention with community, which I'll be talking about today, as well as sharing some of our lessons learned and ways in which we're trying to address the gaps and look forward to next steps. So despite the role and the need for rehabilitation, few individuals living with HIV in Canada have the ability to access traditional forms of rehabilitation, such as physiotherapy. And a number of years ago, I reached out to the Toronto YMCA about partnering in a way that we could look at rehabilitation from a broader self-management framework within a community-based setting. And this led to the CVE study for short, which was set out to evaluate the impact of translating a community-based exercise intervention to enhance health outcomes for adults living with HIV. This was a big undertaking of a project and a huge amount of dedication undertaking by participants who engaged in a 22-month intervention study that involved 3 phases. The first was a baseline monitoring phase, which was 8 months of business and life as usual, followed by a phase 2 6-month intervention, whereby participants were provided YMCA membership. They were placed on an exercise program and encouraged to exercise 3 times a week, one of which was supervised by a personal trainer at the YMCA and progressed as tolerated. Participants were also provided with a Fitbit SIP and encouraged to attend monthly in-person self-management education sessions, and all of which were recorded and can be accessed at this link here on the slide. At the end of the intervention, participants then engaged in an 8-month phase 3 monitoring phase where participants still had access to their YMCA membership, but no longer the personalized one-on-one training, because we wanted to see the level of the uptake and sustainability of the exercise in an independent way. Every 2 months, participants took part in a fitness assessment at the YMCA, as well as self-reported questionnaires, and a subsample of participants engaged in qualitative interviews at baseline, midway, and at the end of the intervention. Among the 108 participants who had initiated the study, 80 or 74% started the intervention at that phase 2. And of those who started the intervention, 84% completed. And of those who completed the phase 2, 77% went on to complete the follow-up monitoring phase. So when looking at the engagement, overall, this was roughly a 50% retention rate over the course of this 22-month study. and a very high level engagement among participants who initiated the intervention. Our primary outcome from this study was VO2 peak, and focusing very much on a silo-based physical form of wellness in this particular talk. We focused on VO2 peak as a primary outcome.
On s'est concentré sur le VO2 comme un marqueur de maladie cardiovasculaire et un élément prédicteur de problèmes cardiovasculaires à l'avenir. C'était un de plusieurs résultats sur lesquels on s'est penché. Mais les gens qui ont participé à l'analyse VO2, la majorité, c'était des hommes, 51 ans, et ils avaient plus de 4 comorbidités. Ils avaient beaucoup de dépression et d'anxiété et de la douleur aux articulations. Un tiers des gens avaient un emploi et faisaient de l'exercice depuis plus de 6 mois déjà. Quand on s'est penché sur l'intervention de la deuxième phase de 25 semaines, les participants sont allés à une moyenne de 18%.
So looking at our primary outcome of VO2 peak, you can see here, ranging across all 3 phases of the study, there was quite a bit of variation in VO2 peak, not only between individuals across the sample, but also within individuals over time. At the start of the intervention phase, the baseline VO2 peak was 24 mils per kilogram per minute in males and 17 for females. And to give you a source of reference, in the general population, for males, it's 35 to 40 mils per kilogram per minute, and in females, 27 to 30. And this is consistent with the literature as well, that shows that people living with HIV have slightly lower VO2 peak or max compared to general population. Now, if we look at the trends between phase 1, phase 2, and phase 3, there was a significant improvement or increase in VO2 peak in the intervention phase, followed by a reduction of that improvement in the monitoring phase. But the improvements seen in phase 2, that rate of improvement was no different than that seen in the baseline monitoring phase overall. We also assessed self-reported physical activity using something called the Rapid Assessment of Physical Activity questionnaire, with higher scores indicating greater engagement in aerobic physical activity. Here you can see in phase 2, there was a significant increase in self-reported aerobic physical activity, followed by a somewhat significant drop in trend compared to the intervention phase in the follow-up monitoring phase. Now, to get out a little bit of the physical form of wellness and broadly look at some of the other aspects of wellness in the study, I'll just wanted to feature one component of the qualitative interviews, of which we were able to look at with 11 participants in the study. And this particular quote speaks to a woman's experience at the end of the intervention that talked about the impact of CBE on her knowledge, mental health, stigma, as well as social engagement. So there's aspects here that she quite eloquently touched upon in terms of emotional and mental health, mindful or mind being better, sleep health, as well as the ability to interact with people. So in terms of some take-home messages, with respect to VO2 peak and aerobic physical activity, we did see increases with the intervention, but they were not necessarily sustained in the follow-up. And you know, there's a number of different reasons for that, and one of which is that the intensity and frequency of exercise in the intervention may not have been enough to provoke a change in VO2 max types of measures. However, individually we see some elements of impact among participants. And particularly, I think a lot of lessons learned from an implementation science approach, that this is not a one-size-fits-all, that episodic health also reflects episodic exercise. And there were a number of complexities that came from personal and environmental factors and barriers to participation, which for this particular study, with the majority being men, there were barriers faced among women participating in this study. So looking at the guidelines, the World Health Organization has also been adopting a little bit of a broader view when it comes to wellness, but also physical activity, and now has encompassed not only physical activity, but sleep and sedentary behavior within what they've called their 24-hour movement guidelines. So these guidelines suggesting that individuals engage in 150 minutes or more of moderate or vigorous aerobic physical activity a week, muscle strengthening at least 2 days a week, several hours of light physical activity, and limited sedentary time, which is less than 3 hours screen time, which for many of us actually is quite difficult during this time. Another lesson learned were the considerations in approaching a community-based exercise intervention. And I've had the opportunity to work with physiotherapy students at the University of Toronto who have conducted a few different research projects in collaboration with Casey House as well as the YMCA, looking at some of the factors to consider when implementing an intervention such as this, the experiences participating in the exercise intervention, as well as just factors to consider whether someone might be ready to engage in exercise or not at a given time. And certainly this work has highlighted the variable structural, geographical, personal, as well as financial barriers to engaging in physical activity, and most recently, the COVID-related barriers to exercising in traditional forms of gym environments. So some of the next steps that we're looking towards is with funding from the Ontario HIV Treatment Network ENGAVE program, we're launching a pilot study to evaluate the implementation of an online web-based telecoaching intervention for adults living with HIV. And this will include 30 adults living with HIV in Toronto who are part of the Ontario cohort study. And this was derived actually particularly trying to address the barriers to participation that we found in the original study, which were largely limited to women who geographically couldn't make it physically to the YMCA downtown and had other child and family care responsibilities. And our primary outcome for this work will be engagement in physical activity and also looking at cost as a feasibility outcome as well. When thinking about sustainability longer term, I've had the opportunity to collaborate with Francisco Ibanez Carrasco, as well as a number of ambassadors in HIV in Motion who are leading a community of practice called HIV in Motion. It involves a number of different stakeholders internationally with the aim to mobilize knowledge, build capacity, as well as partnerships in HIV, physical activity, and exercise. There is a website here if anyone would like more information. And the community of practice hosts online quarterly sessions, and the next one up and coming is May 4th, 2021. And lastly, just wanted to finish off by thanking everybody, particularly the study participants for their dedication to the CBE study, as well as all the partners who are involved in the CBE study and HIV in Motion, as well as the up and coming telecoaching study. So thank you.
Thank you so much, Kelly. We really appreciate you sharing all of that and having attended